All right, I will start our recording here and welcome everyone to our UCSF Orthopedic Surgery Grand Rounds. Today we have one of our faculty members at UCSF to speak to us, and for an introduction, I'll turn it over to Dr. Utku Kandemir.
Yes, today we have Dr. Jenny T, or Dr. Jennifer Tangtiphaiboontana. Hopefully I'm not butchering the name. The last name is a memorable last name, obviously. She's one of our graduates. She went to Stanford for college, then medical school at UCSF, and she joined our residency program. And she passed the endurance test during the residency for sure, but she wanted to get more training. And with her interest in shoulder and elbow, after doing a trauma fellowship at Harborview Medical Center, she went to Mayo, the Mecca of the elbow, and she did a shoulder and elbow surgery fellowship. Then she joined our group, and she's a colleague of mine and ours. So she will talk us today about post-traumatic elbow stiffness. It's a very complicated wide spectrum problem that she's gonna summarize for us, then will make us more knowledgeable today. Thank you, Jenny.
Awesome. Thanks for that introduction and allowing me to talk about a topic that I think is really interesting, but also extremely frustrating at the same time. Let's see. So I have no sort of disclosures that are relevant to this talk. So briefly, just to outline what I'll attempt to cover in under an hour is to review some pertinent patient history and symptoms and specific exam findings, go over sort of the various treatments that have been studied for post-traumatic elbow stiffness, and really kind of, I think, more importantly, highlight some of the important takeaways that I've learned in my training and cases I've been involved in. As the title suggested, things that I won't be covering in this talk for the purposes of time are elbow instability, issues around non-union or malunions around the elbow, and any pediatric elbow issues. So elbow fractures, as we all know, come in a wide spectrum of injuries, so ranging from simple elbow dislocations and olecranon fractures that are fairly common to more complicated, complex injuries such as terrible triads, montasias, and comminuted interarticular distal humeruses. As you go along the spectrum, obviously the injury to the soft tissue continues to increase as well. Elbow stiffness is a pretty common complication, or maybe even some would say an expectation as a result of elbow trauma. And when patients lose up to about 50 degrees in their arc of motion, it can cause a pretty significant dysfunction or disuse of that arm. Of those who go on to develop stiffness, 12% or so requires some sort of secondary operation or secondary intervention to help restore their motion. So this is a very busy slide. When a patient comes to you with elbow stiffness, it's important to really focus and get a really good history, as most other orthopedic injuries. I think of this list, a couple of things I wanted to highlight was really sort of the location of the pain. So if patients can identify one specific spot, that's typically bodes well in terms of being able to help them sort of surgically. I think having a heightened antenna for evaluating for nerve symptoms is also really important, specifically around the elbow. We often think of nerve symptoms as the presence of, tenals or neuropathy, but they can often commonly just present as just pain alone. And then also understanding the patient's occupation as well as their physical demands, just so you can help guide their treatment and counsel them on what might be the best. And then physical exam, again, making sure you have a really good motor and sensory exam, and then specifically with motion, seeing if there's a firm endpoint, which would suggest that there is a mechanical or bony block or a soft endpoint, which might suggest a more soft tissue issue, soft tissue problem. So specifically about physical exam, normal motion for patients obviously vary. So hopefully if they don't have an injury to the other side, you have that as a comparison. But the normal flexion extension arc of motion has been described from 0 to 140 degrees. Dr. Mori described a functional arc of motion of 100 degrees, so from 30 to 130. The important thing to note when you are measuring extension and flexion is to make sure that when you're measuring extension, that the patient is in full supination. As you can see illustrated in this video, the arm is pronated. It actually gives you the false sense that they actually have more extension than what they actually have. So what about pronation and supination? So functional arc of motion is 50 degrees in either direction. And usually this is done, examined with the patient's elbow sort of locked at the side at 90 degrees, asking them to pronate and supinate. Sometimes patients can compensate by pronating and supinating through the wrist. So, and it's a little bit hard to evaluate. So if you really have a hard time, what you can do is have them hold a pencil, and that can also help delineate or be a little bit more objective about their motion. Pronation in general is more important for the use of writing and eating. Although if patients lack pronation, this is typically well compensated through shoulder abduction or shoulder movement. Loss of supination, unfortunately, is not quite as well tolerated, since patients tend to have trouble with personal hygiene, opening doors, and accepting objects with an open palm. So what about diagnosis-specific exams? So if a patient presents with a painful arc of motion, that would suggest an intra-articular problem or potentially ulnohumeral arthritis. If they have pain at the end range of motion, also called the anterior posterior arm bar test, where you're forcibly extending the arm or forcibly flexing the arm or the elbow, what that can suggest is that patients have pain or stiffness that's generated from impinging osteophytes. The radiocapitellar load test, which is done and shown in the image at the bottom right-hand corner, as the arm is placed in full pronation to load the joint, and as the patients resist extension, that loads the joint even more, and if that elicits their pain specifically over that joint, that would suggest issues in the radiocapitellar region. And then again, making sure that we evaluate for nerve issues such as Snell's, motor and sensory issues as well. So there are several ways that elbow stiffness has been classified. A lot of it is mostly derived based on what causes elbow stiffness, or the intrinsic factors, extrinsic factors. I think for the purposes of this talk, I wanted to frame it mostly through these three entities. So soft tissue contractures, formation of HO, and then also post-traumatic arthritis. So with soft tissue contractures, there have been several animal studies as well as human studies that have looked at, what does the capsule actually look like? And so what they found is that contracted capsules are thicker. They tend to have higher amounts of collagen synthesis as well as disorganized fibers, and also decreased pliability, which kind of makes sense with resulting decrease in proteoglycan and water content. The culprit cell is myofibroblasts. They found that there's an increased amount, more specifically actually in the anterior capsule of the elbow as opposed to the posterior capsule, which I think also clinically correlates with the fact that a lot of patients tend to lose or lack extension after elbow trauma. Contractions tend to happen when the soft tissue compliance reduces, and usually it's a cascade of events that results from bleeding, surrounding edema, and then granulation tissue and fibrosis that ultimately lead to loss of motion. So are there things that we can do to help prevent this? So typically we try to limit the amount of immobilization as possible. So getting patients to move earlier, getting them plugged into therapy. There's some thought that extension splinting actually is helpful. So what extension splinting does is it causes sort of more pressure, resulting in less bleeding, and also resists fluid extravasation into the soft tissues. So there's some people who advocate for extension splinting to help prevent stiffness. And then also, as mentioned previously, is making sure patients have adequate pain control. So using anti-inflammatories, neuroleptic medications to help assist patients with their therapy. So before going on to some of the treatment options, I want to just take a moment to kind of acknowledge that pain and psychosocial factors can play a significant role on the patient's outcome as well as their health status. So there have been several studies looking at pain, presence of depression that contribute to patients' ability to engage in their care as well as their perceived outcome. So I think having acknowledging that this is a factor can help, as you see them in clinic, to counsel them and encourage them that they should be moving their elbow, and obviously getting them to the right resources if they are struggling with pain and or other psychosocial issues. So non-operative treatment for soft tissue contractures. Generally, this is indicated for patients with minimal contractures under 6 months. Physical therapy tends to be the mainstay. If patients tend to not progress, then there's utilization of bracing. And then some people also consider manipulation under anesthesia. So with bracing, there are two main options that are typically used. The first one is what's called a dynamic splint. So this is an adjustable spring loaded splint that exerts a constant force on the elbow. The benefit of this brace is that it allows for continued elbow motion, and it utilizes the concept of creep, which allows for increased length of the muscles over time with a constant load being applied. The downside of this splint is that there are some people who feel that the splint itself is less tolerable. Patients tend to complain of more pain, and so might not be quite as effective. In contrast to that, there's a splint called the static progressive splint or a turnbuckle splint, where the maximum load that a patient will tolerate is applied. The difference here is that it's a static splint, so the elbows don't move, and utilizes the concept of stress relaxation. So as the muscles lengthen over time, the amount that it takes to get there is reduced. So what's the evidence between the two? Is there one that's better than the other? So this was one, and probably I think the only randomized study that looked at patients, or the only randomized study that compared the two. And their inclusion criteria were patients who had greater than a 30-degree arc of motion loss and no change or no progression over a month. And essentially what they found, and just demonstrated in those graphs there, is that there's no difference in the amount of motion that patients gained with either brace. And the improvement in the dash scores also was similar, and there was no change really. So their conclusion was that there was no difference between the two braces, and that you can actually continue to see improvement up to a year of using the brace. The other thing to note about this study is that it was a pragmatic study, so they didn't really assess compliance. They prescribed the brace, but patients were allowed to use it as much or as little as possible. So they just wanted to see, if we prescribe it, how do they do? This was a recent systematic review that included the previous randomized study, but also included 7 other retrospective studies. And again, they found the same thing. Static and dynamic bracing resulted in a similar improvement. Again, also sort of concluding that there was really no difference between the two. So the main takeaways from bracing, at least what's currently out there, is there really is no difference between the two methodologies, and that motion can actually improve up to 12 months. So then what about manipulation under anesthesia? So manipulation under anesthesia, I think for the knee, has been well studied and well described. For the elbow, it's generally easier to achieve flexion as it is to achieve extension. And the benefit of this is that it's a single event for the patient to jumpstart elbow motion. So it's a lot more convenient, I guess, for patients and even the treating surgeon. The potential downsides to MUA, especially in a post-traumatic setting, is the risk of fracture. There's also a risk of injuring or irritating the ulnar nerve, especially if they lack preoperative flexion. And also, there are some studies that have suggested that there's a formation of HO after MUA as well. However, that being said, overall, there's pretty limited evidence for MUA of elbow stiffness. This was a study that was done in 2018. It was a retrospective study of 45 elbows that underwent an MUA. And what they looked at were two groups, the ones that got manipulated before within 3 months of injury, and ones that were manipulated after 3 months. And what they found is that manipulation within 3 months was actually more effective than the later group. So they found that those in the early group had an increase of 40 degrees in their total arc of motion as opposed to 3 degrees in the later group. The late group also, what they noted is that patients tended to lose motion after the manipulation as well. The interesting thing I think about this study is, even though they say that early manipulation is probably more effective, what is noted in the chart there is if you look at their preoperative MUA arc of motion, the late group actually had more than the early manipulation. And so, some of the criticisms of this study is, are we intervening too early? Would the natural history of this, if you waited, be just the same? And the other sort of limitations is that only a small amount actually used bracing or were prescribed bracing. And then the post-manipulation rehab really kind of varied between the two. So I don't know. I mean, I think it seems encouraging that early manipulation can be helpful, but I'm not personally entirely convinced that a late manipulation necessarily means that it's a bad outcome. But I think the authors of this study, what they argue is that usually in an urban setting, obtaining bracing is pretty challenging. So that manipulation would be a good option for those who don't have access to good resources. This was another recent retrospective study looking at 12 patients who underwent MUA. And essentially what this study concluded or argued is that MUA is not only effective for both motion loss and flexion extension, but it also can help with forearm rotation. So takeaways, it seems like it's an effective treatment for elbow stiffness. Unclear if it truly is less effective after 3 months. It's a good option for those who can't obtain the static bracing or dynamic bracing. And in general, is recommended to avoid in patients with preoperative ulnar neuritis or heterotopic ossification. So moving on to operative treatments. So open surgical release of soft tissue contractures is the sort of gold standard for it. There are several approaches that have been described. So the lateral approach, also known as the column procedure, is probably the most common one that is used. It allows access to the anterior and posterior compartments, as well as the radial head. It preserves the ACL, or you make sure you preserve the ACL, and it's a relatively simple approach in the sense that you identify the supracondylar ridge, which is a fairly palpable structure, and you extend that distally either through a Coker interval and or an EDC split, and your exposure's done. The medial approach has also been described as well. And so the benefits of this approach is that it allows you access to the ulnar nerve as well as the coronoid to address any osteophytes that might be there. Obviously, you want to make sure that you preserve the anterior bundle of the MCL. However, in contrast to the lateral approach, it tends to be pretty limited. To get an extensile approach, it's a pretty large exposure with pretty significant morbidity. The other two approaches that have been described are the anterior and posterior approach. The anterior approach, I think, has been advocated for those who have isolated flexion contracture problems, although I personally have never done it myself. And then the posterior approach is a more utilitarian approach, single midline incision that allows access to both the medial and lateral compartment. There are some people who advocate against doing a midline approach, because what you do is you end up elevating really large skin flaps to get to the medial lateral side. And in typically multiply operated elbows, you get formation of postoperative hematomas and wound healing complications. So most of us, I think, tend to prefer the dual approach through a lateral and medial approach as needed. So what about arthroscopic treatment? So I think as elbow arthroscopy continues to evolve, it's becoming a popular method to help with elbow contracture releases due to the fact that it's pretty minimally invasive. Without proper training, it can be technically challenging, just with the proximity of the ulnar and specifically the radial nerve. When done, it can be done in a supine or lateral position, depending on your comfort or how you've been trained. So in a supine position, an articulating mechanical arm holder is usually used. You have pretty easy access to the anterior compartment, but the trouble with this is that even with the mechanical arm holder, the arm can be quite unstable when you're trying to scope and do the work that you need to release your soft tissue structures. In the lateral position, a sort of narrow arm holder is used, and the key with this is you want to make sure that you go as proximal as you can in the upper arm, so that allows you to flex the elbow to do your posterior work, and then also not to get in the way of your instruments when you're working in the anterior compartment. There are a lot of portals that are described for elbow arthroscopy. Specifically for the anterior compartment, there are two main working portals that are highlighted in red. So the proximal or anterior medial portal here, which is usually your viewing portal, and then your mid anterior lateral portal or anterior lateral portal, which is usually done from an inside out technique to make sure you don't get the radial nerve. And this is where your instruments usually come in. The key with the lateral portals is that the more proximal you go, the safer you are and the further away you are from the radial nerve. For the posterior compartment, again, you also have two main working portals. So your direct posterior, which is where your instruments go, and your proximal lateral posterior portal, which is where your camera would go for viewing purposes. With all these described portals, you can also make additional portals proximal to them for the use of placement of capsular retractors to help with your visualization. Not specifically for soft tissue contractures, but there are some other portals that have been described. The distal lateral or the soft spot portal is really good for work in the radiocapitellar joint. And the distal ulnar portal is helpful in patients with capital lesions if you want to do any microfracture work. So some technical pearls that I learned with arthroscopy, as mentioned, the use of capsular retractors, either using a Freer or Howarth, is actually really helpful to be able to see what you're trying to do in a small joint. Fluid management is also really important. So making sure that you use the minimal amount of flow and minimal amount of pressure needed to be able to see what you need to do and avoid extravasation into the soft tissues. This is unlike some of the other joints. Once the elbow starts to swell, then your ability to do what you need to do goes down quite quickly. Limiting the use of suction is also really important, so you don't pull in important surrounding nerve structures. And then if you do have any bony work that needs to be done, usually you do that first before you start doing your capsulotomy. Again, also just to avoid any fluid extravasation. And like with most orthopedic surgeries, making sure that you really, really know your anatomy. The arthroscopic image there demonstrates the ulnar nerve and its proximity to the medial epicondyle. So when comparing open and arthroscopic release, there's really no data out there to compare the two methodologies in terms of which one's more superior. There are level 4 evidence out there that shows that both arthroscopic and open release is a pretty reliable method. So the choice of how you do it really kind of just depends on surgeon preference and also experience. So what do you do about the ulnar nerve? So in patients who have preoperative nerve symptoms or preoperative limited flexion less than anywhere from 90 to 100 degrees, ulnar nerve decompression is typically recommended, and then transpose if it's unstable after decompression. What I wanted to bring to the attention is that there's this concept called delayed onset neuritis that I think was described in the early 2000s, I think, after Dr. O'Driscoll recognized it in his own cohort of patients. And so what this is neuritis or neuropathy that presents after surgery in a delayed fashion when the patients had a completely normal exam immediately after surgery. So they looked at their series of patients who underwent arthroscopic release, and 11% of these patients developed this concept of delayed onset neuritis. And there were 3 different categories or 3 different groups that the patients fell into. One was rapidly progressive delayed onset neuritis. So these patients presented with extreme pain, motor and sensory neuropathy, as well as a loss of motion compared to the days prior to the onset of the neuritis. The other 2 entities, non-progressive and slowly progressive, were sort of mild sensory ulnar neuropathy without an increase in pain necessarily. The mean presentation for the symptoms varied anywhere from 2 to 5 days. And when they looked at risk factors for developing delayed onset neuritis, they found that the presence of HO, any preoperative nerve symptoms, having a less arc of motion pre-op, as well as severe extension loss to be risk factors for developing this entity. So when they identified patients who had this rapidly progressive onset, ulnar transposition was actually performed within 1 to 2 days of diagnosis. And what this chart demonstrates is that their immediate post-op range of motion was about 130 degrees or so. As soon as the neuritis happened, they had this dramatic drop in loss of motion. And then with intervention, patients were able to regain some motion, but they weren't unfortunately able to get back to where they were before the neuritis happened. Those who presented with non-progressive or minimally progressive delayed onset neuritis just had modifications in their postoperative CPM protocol. So then they did a follow-up study trying to look at, can this delayed onset neuritis be prevented? So what they did was they compared or looked at patients who either had no prophylactic release of their ulnar nerve or any ulnar nerve release. And what they found is that the group that did not have any prophylactic release had a higher rate of delayed onset neuritis. So they looked into that a little bit further and wanted to look at, well, if we compare nerve decompression and transposition alone, is there one method that's more effective than the other? Within the decompression group, there were 3 different types of decompression performed. So the standard decompression, which is releasing the nerve anywhere from 8 to 12 centimeters, a limited decompression where it's 8 centimeters or 4 centimeters proximal, 4 centimeters distal to the cubital tunnel, and then a mini decompression where it's about 4 centimeters or so the nerve was released. And what they found is that transposition and standard and limited decompression were equally as protective against delayed onset neuritis. But they also noted that patients who had transpositions tended to have higher complications, higher wound complications compared to decompression. So ultimately what they concluded is that the incidence and severity of delayed onset neuritis can be reduced with either a limited decompression or transposition. When I was in training, we actually they favored the limited decompression option. Again, I think just to avoid the higher rates of wound complication with transposition. So postoperative management after release, there's some people who advocate for the use of CPM, and the concept behind the CPM is that it squeezes out the surgical hematoma and the edema around the elbow, reduces the swelling. It's often described as wringing out a wet towel and allows the elbow to move easily and be less painful. The goal of CPM is actually to maintain the postoperative motion that was gained intraoperatively. And usually these patients are admitted anywhere from 2 to 3 days with an indwelling nerve catheter to help with their pain. The protocol is kind of all over the place, but in general, they recommend 20 hours of use every day for about 2 to 3 weeks. I think some of the biggest barriers in using this is obtaining the CPM machine and getting patients insurance to actually approve the machine itself. complications that can happen, wound healing issues, and also nerve irritation as well. So a similar theme, I think, in my talk is that the evidence behind some of these interventions is really limited. So, what's the evidence behind CPM versus therapy post-op? There was one study that looked just at CPM and found that there was really no difference in the amount of motion that was maintained with or without the use of CPM. However, I'd say that there's more data to come. I know that Dr. Driscoll ran a very large randomized control study looking at this specific question. It's currently being analyzed and in the process of being published. And then it looks like there's also another randomized study that's coming out of the Netherlands or it's undergoing. So hopefully this question will be answered shortly. So moving on to heterotopic ossification. Heterotopic ossification is usually defined as the presence of mature bone that exists within the soft tissues. They can act as both a mechanical block to motion, or they can also tether the soft tissues and make them less pliable. The overall prevalence of HO is kind of all over the place for elbow trauma. So anywhere from 2 to 5% in simple elbow dislocations, and anywhere from 20 to 70% in elbow fracture dislocations. The hard thing about interpreting the data is a lot of the studies tend to focus on the presence of radiographic HO. But how much of this is really clinically relevant is sort of unknown. So we know that burn patients and patients who have injury to their CNS system, either traumatic brain injury or spinal cord injury patients, tend to have a higher risk of developing HO in their joints. However, injury-related factors have also been identified. So those who have longer duration of their dislocation, patients who underwent multiple reduction attempts, so specifically for terrible triads, greater than 2 reduction attempts have been found to be associated with higher risk of HO. Surgical timing also, there have been several studies that have suggested that fixing these in the more acute setting, so within 24 to 48 hours, can result in lower rates of HO formation. There was a study done by Furriera, also out of Mayo, that found in their predictive model that the risk of HO tends to increase by 7% daily with every with surgical delay. Fracture type also seems to matter. So again, I think suggesting that the higher energy, more injury to the soft tissues, the higher rate of developing HO, and also the duration of postoperative mobilization potentially could play a role. There have been several ways that HO has been classified in the elbow. Unfortunately, none of which I think are particularly universally accepted or useful. So this is the Mayo radiographic classification. I think it's mostly for research purposes and trying to identify this entity. The Berker classification, which is well known, for the hip, has also been modified and applied to the elbow. The one classification system that potentially has some use, I think, is the Hastings and Graham's classification, which incorporates the functional aspect of it as well. So, is there radiographic HO present, yes or no? And then if so, what's the patient's motion? And, this may also, I think, better, I think for the purposes of research, help us understand which of these patients could potentially benefit from some surgical intervention or better identify a clinically relevant HO. So imaging studies, so serial x-rays, I think, are very helpful to identify, one, patients who are starting to develop HO, but also to see how it's progressing. There was a study done at Stanford that found that of the patients who developed HO, again, also just radiographic, 86% of them actually had some evidence on their 2-week post-op x-ray. They also found that if there was no HO present on their 2-week post-op x-ray, only 14% of them went on to HO. So I think what my takeaway from this is, should we be getting x-rays at 2 weeks to help counsel the patients? However, again, I think as mentioned, whether or not that goes on to become clinically relevant is unknown. Unlike the hip, the HO in the elbow tends to mature by 3 months or so. And so I think once you've had serial x-rays up to that point, and depending on their motion, I think at that point you can then start counseling the patient about intervention and what they'd like to do if they're still having functional limitations. CT scan is and 3D reconstructions are critical if you reach a point where the patient that they want surgical excision. There's a study that describes identifying the location of the nerves relative to where the HO is formed. And so the ulnar nerve, the radial nerve, and the median nerve can be tracked. I think it takes a little bit of experience and time to be able to do this, but I think it's also very important to know where everything is before undergoing excision, just to make sure that you're safe. So open excision is probably the most common approach that people use when excising HO. Arthroscopic excision has been described, although it usually is only done by those who are pretty experienced. So I think the open excision, if you're not quite facile with arthroscopy, is probably the safest option. So the goals of surgery obviously are to restore motion, so releasing any soft tissue, contractures, if there's any concomitant damage to the articular surface, specifically the radial head, doing any partial reconstruction or replacement, and then also always being prepared to repair or reconstruct the ligamentous structures as needed to make sure that the elbow is stable post-op. The important thing with post-traumatic elbow is making sure that you completely do your release first before you start removing any hardware that might be impinging, just to reduce the risk of fracture. How you approach HO, I think, is largely dictated by the location. Again, it can be done through a single incision, sort of posterior midline and approach, or dual incision. Again, those who advocate, there's a group of people who advocate against the posterior single midline incision, again, to avoid elevating large flaps. So what about timing? Unlike the hip, there's some evidence to show that excision early on, so within 3 to 6 months or so from injury, actually does not result in higher rates of recurrence. I think in the hip, there's some concern that if you excise the HO too soon before it matures, then there's a higher rate of recurrence. However, that's not true for the elbow. And then what about prophylaxis? So a lot of these patients tend to get either radiation or anti-inflammatories after surgery. For radiation, patients either tend to get a single dose of radiation within 24 hours before or within 72 hours after surgery. In this systematic review, they found that radiation used for secondary HO prophylaxis had a 15% rate of recurrence, and that there really was no difference between pre or post-op radiation. The struggle with radiation is that there are often logistical issues and difficulty with hospital resources, so it may not always be readily available for patients as a treatment option. Anti-inflammatories, I think, is also another common thing that's used. So endomethacin, usually about 75 milligrams daily, taken anywhere from 2 to 3 weeks, depending on the surgeon's protocol. The trouble with anti-inflammatories is sometimes patients don't tolerate it very well, and there's a potential compliance issue. Right, so moving on to post-traumatic arthritis. So I just wanted to review again just some key evaluation points that I mentioned at the beginning. So really sort of soliciting the patient's primary complaint. Is it a pain problem? Is it a motion problem? Is it both? And then if it is pain, really kind of understanding where their pain, where it occurs. Does it occur at end range of motion? Does it occur through through the mid arc of motion? And I would say that if patients tell you that they've got pain at rest or pain all the time, that this might be a caution sign, and that you should really look into, history of infection or presence of infection, presence of complex regional pain syndrome, and or the presence of nerve pain. So with the goals of operative treatment for post-traumatic arthritis, the goal is to restore a pain-free or minimally painful functional joint while preserving future surgical options. So what this means is, not every painful post-traumatic elbow should get a total elbow replacement. I won't spend too much time on arthroscopic debridement since we talked about it, but again, main indications for this are patients who have stiffness and pain at the terminal motion or terminal flexion or extension. Again, CT imaging can be helpful. And overall, the studies out there looking at the outcomes have reported good to excellent outcomes in a majority of patients who undergo this procedure. So interposition arthroplasty has been described to treat post-traumatic arthritis, specifically in younger patients. And what this is, it's a resurfacing procedure that uses either auto or allograft to help cover the distal humerus articular surface. Indications are typically painful post-traumatic arthritis in young patients or higher demand patients. Contraindications to this procedure are the presence of infection, the patient doesn't have any adequate bone stock, they've got poor flexion strength, and preoperative instability. The interesting thing too is load-bearing activities is also a contraindication because it can result in early failure as well. So this was a study done also out of Mayo in 2008, looking at 69 elbows that underwent interposition arthroplasty and the duration or durability of the procedure. And so what they found is that the survival rate of the procedure was 90% at 5 years and 80% at 10 years. Poor outcomes were associated with instability, deformity, and marked pain. Again, sort of having either preoperative or postoperative instability seemed to really affect the outcomes and result in lower scores. So that's one thing to be aware of if you are considering this treatment option for a patient. So interesting enough, you put a big piece of tissue inside a joint, you tell the patient to go and use it. What happens to the graft over time? And so in this small case series, they looked of patients who underwent revision intra-arthroplasty. Again, there's only 9, but what happens to the graft? So those who had an Achilles allograft, there was graft sort of still present. It's in some part of the joint in one patient, and then in 3 patients, their articulation was bare, but the graft was still present anteriorly posterior. Autogenous fascial autograft is also a described tissue that's used. Interesting enough, by the time these patients underwent their revision, there was really either no graft or just fibrous tissue left. And so I think this study highlighted the sort of preference to use Achilles allograft over an autogenous graft when doing an interposition arthroplasty. So, if you offer an interposition arthroplasty, how do total elbows do afterwards if they fail? Are you burning any bridges? So again, in this study of only 12 elbows, again, small numbers of patients who underwent a prior interposition arthroplasty and then subsequently treated with elbow replacement actually did quite well. So majority of the patients reported either mild to no pain at a mean follow-up of 10 years, and their outcome scores or elbow outcome scores also improved significantly in that time frame. Within that, there were only 2 revisions, one for bushing wear, which can be pretty common and expected, and also humeral osteolysis around the humeral component. So I think what they sort of concluded is that total elbow is a reliable pain relieving option with successful outcomes even after interposition arthroplasty. So I don't think you're burning any bridges necessarily by offering an interposition arthroplasty for younger patients as a joint salvage procedure. So total elbow arthroplasty is a huge talk in itself, so I'm going to be very brief. But in general, it's an acceptable first-line treatment for elderly patients and those with low demand. What has been shown is that elbow replacement, specifically for post-traumatic conditions, results in higher failure rates compared to those who receive it primarily for rheumatoid arthritis or primary OA. And I think a lot of this is a result of the fact that post-traumatic elbows are typically operated on at least 2 or 3 times by the time before they actually get an elbow replacement. So you've got compromised soft tissue envelopes, increased risk of infection and problems with poor bone stock or bone stock loss and instability. And then, most people know, the biggest hindrance in offering this as a first-line treatment for everyone is the postoperative restriction. So typically it's a 10-pound single event lifting restriction or 2 to 5 pound repetitive lifting. So most of these post-traumatic patients tend to be younger, tend to be higher demand. So I think that contributes also, I think, to the higher rates of failure seen. When doing an elbow replacement for post-traumatic conditions, you want to incorporate any old scars as possible just to reduce any compromised blood flow to the skin flap. Most people would argue to transpose the ulnar nerve. When doing a total elbow, you can either do it with a triceps on or triceps off approach. I think that the triceps off approach is beginning to fall out of favor, with most of us doing triceps on just to reduce the risk of extensor mechanism disruption post-operatively. The other important key is if patients do develop or present with concomitant soft tissue contractures, you want to make sure you do an extensive release. And you don't want to force the implants together or to link together, because then what that does is it transmits the forces to the stem and can potentially cause early implant failure. And the last thing is really trying to avoid impingement of the implants through an arc of motion. So once you've got your trials in, making sure that the coronoid isn't impinging on the humeral component, as this can cause a pistoning action on the ulnar side and also contribute to early failure of the implant. So, I mentioned that there's a higher rate of failure with elbow replacement and post-traumatic arthritis. So this was another study that looked at 85 total elbows that were performed for specifically for post-traumatic arthritis. And what they found is that there was an improvement in pain scores, elbow motion, and overall patient-reported outcomes. So again, a very good option for post-traumatic arthritis. However, the complication rate was as high as 34%, both if you include implant-related complications and non-implant-related complications. Of the implant-related failures, about 19%, and this kind of varied based on the time frame. So early failures or less than 5 years were a result of infection. The 5 to 10 year failures were mostly due to bushing wear. And also the late failures were due to component fracture and or loosening. They found that this overall survivorship at 15 years was about 70%. But I think the most important thing when you're looking at total elbow literature, elbow arthroplasty, and is understanding that elbow replacements, unlike the hip and knee, is still sort of evolving. So design implants are continuing to change. There's a better understanding is continuing to evolve. And so it's important to look at what implants were used in interpreting this data, because the current implants that are out there, we only have short-term outcomes, we don't have long-term, and so these failure rates may not necessarily apply as the designs continue to change. And then lastly, elbow fusion for treatment of elbow arthritis. So usually this is a treatment of last resort for patients, just because of the inability to really compensate for loss of elbow motion. The elbow is pretty important in placing your arm or your hand in space So when you fuse the elbow, the shoulder and the hand and wrist really don't compensate for it very well, but it is a good pain relieving option. In terms of where you fuse the elbow really kind of depends on the patient's demand and also the planned use. Some people would argue that if you fuse the elbow at 90, it's good for manual labor just because that positions the hand and wrist in the optimal position for strength. It's also good for the dominant arm. If your patient has any lower extremity dysfunction and needs to use assistive devices, or they work a lot on the computer, fusing in 30 to 45 degrees may be better. And then if it's their non-dominant arm and they use that for personal hygiene, having it in that degree of extension may also be also helpful as well. Some things that you can do to assess what would be the optimal position is putting the patient in a hinge knee brace and asking them to go home and see what position is actually best for them, and then using that to guide what position you would fuse them in. So I know that was a lot of information, but in summary, I think careful history and physical examination and evaluation is critical when evaluating patients with post-traumatic elbow stiffness or even any sort of problem. Soft tissue contractures can be successfully managed non-operatively if caught early enough. Early excision of HO, I think, is safe and does not require, or does not result in higher rates of recurrence, and that the optimal HO prophylaxis postoperatively is still kind of pending or unknown. And then, like most things in orthopedics, having a shared decision-making model discussing sort of the pros and cons of each procedure is crucial in offering the best care for your patients. Thanks so much.
All right. Thanks, Jenny. That was great and definitely a challenging topic, but a lot of good information. I see our first hand up from Dr. Emmerman.
Hey, Jenny, it's Igor. Thank you very much for this talk. I have so many questions, but I'll just start with one. So about ulnar nerve management when you're doing arthroscopic release, what are the indications to do an ulnar nerve release or transposition, and when do you do it, or when do you prefer to do it? Immediately before you do the arthroscopy, like maybe right after in the same operative session, or actually staging it?
Yeah, so I think at Mayo, most of us I think they've been doing it. So if the patient doesn't have any preoperative nerve symptoms, they will do it prophylactically. And so what they do is they do it before they do the arthroscopic portion. And the skin incision itself is pretty small. It's only about 2 to 3 centimeters. And then they just, release 4 centimeters, proximal 4 centimeters distal. So that's for patients who don't have any preoperative symptoms. If they do, and the nerve is unstable and it needs to be transposed, then they'll do it in a staged fashion to avoid any wound healing complications. So that's typically what I've seen for ulnar nerve stuff. But you could argue that by releasing patients who don't have any symptoms might be a little bit overkill. But the morbidity, at least of their limited approaches, is pretty small.
And so if they do a transposition, they do it later, like a week later, 2 weeks?
Usually they wait about 4 to 6 weeks.
Okay. And then like when do you decide who needs it? Is it because of the amount of contracture that makes you?
It's less so about the contracture, more about their preoperative like symptoms. So that they've got like obvious neuropathy and the nerve is unstable, but less so about the lack of motion.
No, I mean they just decide to release. Like everybody gets it?
Yes. Like I said, some people would say it's probably overkill, but yeah, the standard there is almost everyone gets it.
So even if it's like, I don't know, 30-degree loss of motion, like they're almost, they don't have a lot of flexion extension contraction. They just, okay.
Great. And then I think Dr. Candemir had his hand up next.
Thank you, Jenny, for this thorough review of the very complicated topic. You touched upon it a little bit, but my question is about the timing of the when you decide to intervene, especially like when there's a soft tissue only problem versus bony problem too. You said like when the inflammatory phase is over, but is there any objective way to know when this inflammatory phase is over? Can you comment on that?
Yeah, I mean, unfortunately, I don't think there is. I mean, I think you could probably use pain as a surrogate for the inflammatory process. I think in making this talk, I was actually more encouraged by non-operative treatment of soft tissue contractures than previously thought. But I think with HO, if they present with painless or relatively painless stiffness, and there hasn't been any progression over at least 3 months of radiographic imaging, that's probably a safe time to intervene.
So I think question from Dr. McClellan.
Yeah, Jenny, great talk. There was a recent meta-analysis on ulnar nerve management with distal humerus fractures, and they concluded that leaving the nerve in situ was more advantageous. And I seem to be a magnet for distal humerus fractures. I've probably done 40 to 50 in the last 35 years. I've never transposed that I can recall the ulnar nerve, and I just don't really see ulnar neuritis after leaving it in situ. You just got to be careful with your medial plate and get some soft tissue coverage over it. But do you have any, it seems like the ulnar nerve is the real bugaboo here, what to do with it regarding
I think
elbow type surgery.
Yeah, I think, I've definitely gained an appreciation for the ulnar nerve in my training thus far. But I think for post-traumatic stuff, it's a little bit different. For acute distal humerus, I think I would agree. I've looked at that literature as well, that, obviously the trauma bias is that you leave it in situ. Maybe shoulder elbow training is transpose everything, which I don't necessarily agree with. So yeah, I mean, I don't routinely, it's an extra CPT code. But I don't routinely transpose the nerve unless the patient actually has like symptoms preoperatively, which you could argue is hard to determine when they're in a bunch of pain. And the other sort of indication to transpose, I guess, is if your plate. Some people use plates that go all the way down to the trochlea, and the nerve lies right over the plate. So that would be another indication. But I think there's some other studies that have talked about, or that have shown that transposition actually is worse. And the theory behind that sometimes is if you devascularize the nerve while you're doing your release and transposing it, that can also cause a problem. So yeah, but I think in my practice, I don't routinely transpose, for in the acute setting.
All right. Any other questions or comments?
Just a quick one, Jenny, thank you for your presentation. Great to have you back on the faculty with all of your expertise. It's spectacular. Just on the total elbow, I was intrigued, those failures from loosening and bushing failure related to the constraint of the device. Are the newer devices dealing with that, creating a different bearing? What you alluded to the fact that the results might be better. What do you think is fundamentally different?
Yeah, so the bushing wear has definitely, the bushing design has changed. So the prior total elbow designs was the Coonrad-Mori, which really had a thin plastic. I don't know if it was necessarily, high linked, probably cross-linked stuff. But the newer total elbow options now have a much thicker and wider polyethylene. Again, I think to account for the fact that the smaller it was, the faster they wore out. In terms of component loosening, having a semi-constrained or a linked implant is helpful because it avoids or addresses any instability of the elbow itself, but it does transmit the forces to the stem. So things that have kind of evolved to help offload that are creating, most of them all get cemented, but creating a notch in the ulnar component to help with cement binding using an extra piece of bone graft on the humeral side to prevent posterior translation and rotation of the implant itself. And then Dr. Driscoll, I know, has been doing in a select few unlinked total elbows and modifying his approach to be able to more predictably repair and get his ligament, more predictably get his ligament repairs to heal. He typically does those in higher demand younger patients. Again, I think to offload the stresses through the stem, but it's still unfortunately an evolving field.
Thank you. Tough balance there.
Mm-hmm.
All right. Well, Jenny, thanks again so much for presenting. That was great and a great overview. And then for everyone else, we'll be back in 2 weeks with Dr. Woodbov Sanker from Children's Hospital of Philadelphia as a visiting professor.
Thank you.